Selamat petang dan salam sejahtera. A very good evening to all participants, attendees for our Let's Talk About series. I am Dr. Sivabala Selvaratnam, a practicing obstetrician and gynecologist at Hospital Raja Permaisuri Bainon, Ipoh. And today we are here for episode 6 of our Let's Talk About Menopause, episode 6 of the Let's Talk About series, an initiative by MMA's Women's Health Committee. I would like to give a shout out to the committee members of the Women's Health Committee, namely Dr. Juliet Matthew, as well as Dr. Vani, and Ms. Muthu, who is in charge of the secretariat, and most of all you participants who have been faithfully following us over the last 5 episodes on the Let's Talk About series concerning women's health. It's a Thursday evening at 8:02 p.m. and yet we have got about 122 attendees to listen to our very, very prolific speaker, who, more than anything else, is an empathetic doctor as well. So let me tell you a few words about Dr. Aini Hanan Azmi. She's a practicing obstetrician and gynecologist at KPJ Klang Specialist Hospital. She is a member of the Royal College of Obstetricians and Gynecologists, UK. In addition to her dedication in delivering care for women through various stages of their reproductive health, she has got a particular enthusiasm in the intricate nuances of menopause. And her mission is to provide support for women navigating the significant phase of life through empowerment and education. A few more bits about Dr. Hanan. She is a member of the International Menopause Society. She is a member of Menopause and Midlife Women's Health Subcommittee, which is part of the OGSM, Obstetrical and Gynecological Society of Malaysia. She was awarded the IMS, which is the International Menopause Society, Young Scholar Bursary last year, and was the runner-up for Menopause Olympics at the 19th World Congress of Menopause held in Australia. Mend the Pause, MEND, Mend the Pause pamphlet. She was instrumental in writing, translating, designing, and publishing a menopause patient education pamphlet under the OGSM, which was translated into 4 main languages spoken in Malaysia: English, Malay, Mandarin, and Tamil. Co-authored the Malaysian landmark study, which was Menopausal Symptoms Among Multi-Ethnic Women in Malaysia, which was accepted for publication into Climacteric this year. The Mary Project, an exploration of the mental and physical health impact in menopausal women. She's the site investigator for an ongoing worldwide menopause research funded by Southern Health NHS Foundation Trust, expected to complete next year in 2026. Um, and she's also very, very passionate about her role in the Royal College of Obs and Gynae International Representative Committee, called the IRC. And she's a tutor for the MRCOG exams parts 2 and part 3. So as you can see, we've got a very highly qualified doctor sat here with us on this Thursday evening to talk to us about something that she is truly passionate about, um, which is menopause. But before handing over the stage to her to take us through menopause, I'd just like to ask her and get to know about what it felt like, being runner-up at the Menopause Olympics at the 19th World Congress on Menopause in Australia. I mean, that's no small feat, right? Whenever Malaysians win the World Cup, and then we are all like, all excited. Yes, yes, I'm Malaysian too. So to hear that, a homegrown doctor is going to Australia and getting runner-up at that World Congress at the Olympics. Dr. Hanan, tell us, how did it feel like, and what what was that all about?
Okay, thank you, Dr. Siva, for that very lengthy and very kind introduction. Talking about the World Congress last year, I think it was kind of a stroke of luck, I would say, because I heard about an opening for the bursary. The requirement was simple. You just need to submit your CV and write a short essay on why do you think you should be given the bursary, as in a scholarship to attend the Congress. So, and you have to be less than 40 years old. And so I filled up the form, sent in my CV, write a short essay, and thankfully, I was awarded the bursary, which means that I could attend the Congress for free, and they paid for my airfare. So I think all of you here, don't discount yourself. Just go for it. When you see an opening like this, it's just simple. Write in a short essay, send in your CV. You never know, you might get it. But the thing about the bursary, it comes with the compulsory participation in the Menopause Olympics. It's like a quiz. And I'm a very competitive person, so I know that I would need to participate in the Menopause Olympics. So I studied quite a bit, and somehow I managed to become the runner-up. So that's a long story short.
That's a very, very modest description on how you became runner-up. But yes, there you have it, runner-up of the Menopause Olympics at the 19th World Congress on Menopause in Australia. So, without further ado, Dr. Aini Hanan Azmi, the floor is yours.
Okay, again, thank you MMA. Thank you MMA Kelantan branch for organizing this. And again, thanks to Dr. Siba Bala, Chairman of MMA Women's Health Committee. So without further ado, let's talk about menopause. Sorry, suddenly, all right. So before we start, I would like to rewind 20 years back. I don't know if, I think many would relate with me when I say that if I try to recall what I learned in undergrad days about menopause, I don't remember learning much beyond the definition of menopause. So I think it ties a lot to this paper called the Women Health Initiative, or called the WHI. It was published sometime in 2002, which was publicized. The report was publicized as hormone replacement therapy increases the risk of breast cancer as well as cardiovascular disease. And what it caused was that it stopped almost completely the usage of hormone therapy. Hormone therapy lost popularity among women and among doctors alike, and everyone was scared. Many women who were on hormone therapy before that stopped taking it, doctors stopped prescribing it, and as a result, those of us who were that generation who goes to medical school during that time, we stopped learning about it as well. So what is it about the study, the WHI study? So the WHI study actually investigate the role or the risk of CEE, the conjugated equine estrogen, and the MPA, the medroxyprogesterone acetate, just these two types. However, the results were generalized to all types of hormone therapy. And the second issue with the WHI was that how it was reported. It was reported as relative risk as opposed to absolute risk. And so the results were misinterpreted. For example, 29% chance of developing coronary heart disease and 26% chance of being diagnosed with breast cancer with the usage of hormone therapy. Whereas actually it is relative risk and not absolute risk. But there's no going back from there. Once it is published, everyone was scared. The narrative has been set. There's no going back from there to reset the narrative. And the third issue is if you appraise the study carefully, you would find that only 30% of the participants were actually less than 60 years of age. The mean age of the participants were, I think, about 63 years old. And this is certainly not the age group where women need hormone therapy. We know that women who need hormone therapy are women who are struggling through the transition, the menopausal transition. These are the women in their late 40s and also in the early or mid 50s. All right. So again, this is a roller coaster history of menopause medicine. Actually, the conjugated equine estrogen was first approved way back in 1942, and it gained popularity until it was described as the fountain of youth in the mid 1970s. However, during that time, doctors were prescribing estrogen only, and after some time, they found that unopposed estrogen increases the risk of endometrial cancer, so they stopped prescribing it until the early 1980s, when they found that, oh, actually we can prescribe progestogens as endometrial protection, and it gained popularity and peaked at the early 2000s until JAMA published the Women Health Initiative study, and it goes downhill from there. And we have not recovered in the past 20 years. And I would say we are only just recovering now when we when hormone therapy are starting to become popular again. And we find nowadays that women all over the world, especially working women, are scrambling through the internet looking for information. And this is the time when misinformation becomes an issue as well. So that is why we as doctors need to educate ourselves so that we can provide evidence-based information to our patients, and not, so that our patients don't get influenced by, nowadays they have some coaches, menopause coaches, and, things like that. All right. So I have 3 agendas today. Number 1, I hopefully would like to be able to convince you that menopause medicine is important. You need to pay attention to menopause medicine because it is important. And number 2, I will be guiding and bringing you through the troubleshooting of menopause hormone therapy, because I think this is a tricky part. Because when we don't know how to prescribe, we don't know what to prescribe, we're not confident, so we can't advocate that for our patients. So I'll be talking about the 5 Ws of menopausal hormone therapy. And of course, the third one, no talk about hormones would be complete without addressing the looming shadow of breast cancer. So first things first, why menopause medicine? So number 1, there is a phenomena called the silver tsunami. Malaysia now is an aging nation whereby more than 7% of our population is more than 60 years old. And in less than 5 years' time, by 2030, we're going to transition into aged nation, whereby more than 15% of our population are more than 60 years old. This is a problem because this group of people might not be in the workforce anymore, so they're not contributing to the economy. These are the group of people who are in a poorer health. They are the ones flooding our public hospitals and our healthcare services. And these are the group of people who require care to a certain extent. So it is a problem. And the second issue is that women outlive men on average 5 years. We know for a fact that the life expectancy for Malaysian women exceed Malaysian men. But these extra years are not necessarily good extra years. Many of them, although they live longer, they actually live in poor health, and those are definitely not meaningful years. And another thing that we need to establish is that there is a difference between chronological age, which is your age in your MyCard or your passport, versus the ovarian age. So you might have 2 women who are 50 years old, but their ovarian age might be very different. And this difference determine their actual risk for health morbidity or mortality, for example, risk of osteoporosis and risk of cardiovascular disease. And I would like to bring your attention to perimenopause, because I think in my younger years, I always imagine when people say the word menopause, I would imagine a frail old woman who has gray hair. But actually, we need to spotlight on perimenopause. Is a younger group of women who are supposed to be thriving at work, who should be thriving in their life, but they are actually struggling with perimenopause and also the menopausal transition. And this is also the group of women where who are in the very window of intervention that will be meaningful for their long-term health. And number 5, speaking of prevention, menopause medicine is actually preventive medicine. And what you do now during this very window of intervention determines how meaningful the woman would live later on in her older days. Okay, so this is a hypothetical timeline of a woman in Malaysia. So based on a study, this is an old study done some 20 years ago, we found that average age of menopause in Malaysia is actually 50.7 years. But more recent studies globally have found that average age of menopause is actually shifting younger and younger. In fact, some studies quoted as young as 48. And we know for a fact that, age of menopause is when the periods completely stop. But the transition before that, the problematic phase of transition before that can last on average, sometimes up to 8 to 10 years. So this is a very, very long time to struggle. And taking into consideration the average life expectancy of women, you can say that almost half a woman's life is actually spent in the menopause. And I transpose or I put up some life milestone of this hypothetical woman onto the timeline. So if you take into consideration the mean childbearing age in Malaysia around age of 30, by the age of 45, usually this woman would be at the peak of her career. She might be your head of department, she might be a policymaker, she might be your politician, she might be a leader in, an organization. She's supposed to be thriving at work, but at home, she's struggling with her teenage children. And her responsibility is sandwiched between managing the teenage children and also caring for her aging parents. This is certainly not comfortable, not an easy phase to be in. And what's worse is that this is also the phase where perimenopause happen and where all the menopausal symptoms start to be felt. And a lot of women are struggling in silence, and what happens is that they leave the workforce, and definitely that's a loss for the society. All right. And assuming that she's going to retire at 60, then that's another, 15 years of struggling and, persevering without knowing where to seek help. So speaking about perimenopause, do you need to do a blood test to diagnose perimenopause, or in fact menopause? Actually, you don't need to do a blood test. You can diagnose perimenopause primarily based on the symptoms that the patient have and irregular periods. This is based on NICE guideline. With the exception, if the woman is less than 40 years old, if she has a scanty period, sometimes amenorrhea, you don't have to wait for 6 months. 4 months is sometimes enough, or even scanty periods. You can just do just one test, which is the FSH. And if you refer to the ASHA guideline, the latest guideline, they recommend that you only do one single test of FSH. And if it's more than 25, then you can diagnose the patient with premature ovarian insufficiency. So the reasoning behind that is they don't want delay in starting the treatment. However, NICE guideline, also fairly recently updated end of last year, still recommend more than 30 international unit, and they also recommend repeating within 4 to 6 weeks. You can use whichever guideline that you feel suit your practice. Speaking about women less than 45 years old, these are the women who we say undergo early menopause. Some guidelines recommend that you treat or you see these women as a continuum of premature ovarian insufficiency, and you treat them the same because these are a younger group of women who would need treatment for the sake of their long-term health. But if the woman is 45 years old and older, you just go clinical. You don't need to do any lab investigation where diagnosis is concerned. All right. But always remember to exclude pregnancy and provide contraceptive option if the woman does not desire pregnancy. So there are a lot of symptoms of menopause, and some of them can be very trivial. Some of them can be a bit vague. But I think it helps if you put them into a spectrum with regards of age like this. So in the younger group of women, usually the more prominent ones are the vasomotor symptoms, the mood disorder, and the sleep disturbances. And as the woman age, then you start noticing the genitourinary syndrome of menopause, the vaginal atrophy, dyspareunia, and some incontinence problem. And the most important thing that we want to prevent is the consequences, the later consequences, which the older age group actually struggle with or have to live with, is the osteoporosis, the cardiovascular disease, and also, coronary heart disease. Alzheimer disease actually, I would say, is in a different category altogether. Alzheimer and dementia. Actually, we know that this usually happen in older women and not due to menopause per se. So do not ignore hot flushes. Sometimes patient comes to you and say that she has these hot flushes, this sweating. I think most of us know that those are menopause symptoms, but most of us just stop there. We just tell the woman, oh, I think you're going through menopause. And then the consultation sway to other things that we're more familiar with to manage. But we must not ignore hot flushes. Why? Because number one, hot flushes affect many women. And studies have found that women who experience frequent hot flushes has twofold increase in coronary heart disease, irrespective of other risk factors, if you compare to women with no symptoms. And from studies, we also know that women who experience intense hot flushes have twofold increase in hip fracture because of osteoporosis. So you may ask, why? What does hot flushes got to do with cardiovascular disease, for example? So from studies, we know that it's probably not causation, but it is correlation, probably. So what's probable is that perhaps women who have the tendency to have more frequent and more intense hot flushes also have some vascular properties that make them more risky or more susceptible to have cardiovascular diseases. So this is what I talked about chronological aging versus ovarian aging. So if you look at this graph, you can see at the point of onset of the menopausal transition, there is an inflection point where the cardiovascular risk factor actually steeply increase. And this is irregardless of her chronological age. So essentially, it depends on the onset of the menopause for that particular woman. So that's why I said you can take two women who are 50 years old, but their cardiovascular risk might be greatly different depending on their ovarian age. All right. So what do we need to do to take consideration into managing the menopausal women? Of course, we need to relieve the climacteric symptoms. We need to help her manage the symptoms because it's affecting her quality of life. We want the woman to live her life to the fullest. And by maintaining her quality of life and by relieving her climacteric symptoms, we are indirectly optimizing her long-term health. So the second part of my talk is the 5 Ws of MHD. what I find myself struggle with during my training years was that I know that the woman needs menopause hormone therapy. I know that it will be beneficial for her, but I don't know how to prescribe it, and I'm not confident enough on how to troubleshoot it. So I think that's why we're all here today, because we don't want the lack of information to stand between our patients and relief. We want the best for our patients. First W is who. So who are the women who need menopausal hormone therapy? Oh, first of all, I forgot to explain about MHT. So MHT is menopausal hormone therapy. It's a newer and currently more current term for hormone replacement therapy. So if you hear MHT and HRT, actually people are actually talking about the same thing. But the newer literature usually uses the term menopausal hormone therapy. So who are the women who need menopausal hormone therapy or MHT? First of all, these are the women who struggle with vasomotor symptoms, the hot flushes, the night sweat. So one thing about hot flush is not just, feeling hot when other people are not hot. It's this sudden feeling of sudden intense heat, usually at the upper part of the body. And usually this will be followed by intense sweating. It's because of the changes in the thermoregulatory zone in the brain. The second group of women who would benefit from MHT are the women who has genitourinary syndrome of menopause. So, for example, vaginal dryness, sexual disturbances, urinary incontinence. So previously we used to diagnose as atrophic vaginitis. However, now the more proper term is GUSM or genitourinary syndrome of menopause. Is more holistic and encompasses beyond just atrophic vaginitis. And the third group of women is women who need MHT for osteoporosis prevention. In certain countries, it is not a first-line indication, but if you look in our CPG, yes, our Malaysian CPG actually recommend giving MHT for osteoporosis prevention. So who are the women who cannot use MHT? Number one is women with breast, uterus, or ovarian cancer. And the second group of women are the women with history of blood clots or heart disease, for example, stroke or VTE. All right. The second W of MHT is what? What are the types of MHT that are available and should be given? So this is a golden rule when it comes to prescribing MHT. You need to know whether the woman still has a uterus or not. So if the woman has no longer has a uterus, for example, she has undergone a hysterectomy, then it is simple. She only needs estrogen therapy. But if the woman still has a uterus, you need to give two hormones, i.e. the estrogen and also progestogen therapy. Progestogen's role here is for the endometrial protection to prevent endometrial hyperplasia due to unopposed estrogen. So I think out of all, probably this is probably the most important slide. Again, how to prescribe. Again, golden rule, if the woman has no uterus, simple, you just give estrogen daily. You start with a low dose and you look at the symptoms, you only increase the dose if necessary. It gets a bit trickier if the woman still has her uterus. Then you need to take into consideration whether she is perimenopausal or already menopausal. If she still has her periods, you need to give a regime with regular scheduled bleed. It means that you throughout the month, you give estrogen daily, and out of that 1 month, 12 to 14 days of progestogen. If she no longer has her periods, which means she's already in the menopause, you would give the no bleed therapy. It means that estrogen and progestogen is given daily. There is another group of MHT called the tibolone. The tibolone has an added advantage where it has some androgenic property. So it helps for women, usually younger group of women or surgically menopause women, because it to a certain extent it will help with the libido. But Tibolone you can only give to women who are already menopausal or women who underwent a surgical menopause. Genitourinary symptoms of menopause. For this group of women, you only need to give low-dose vaginal estrogen. If you give low-dose vaginal estrogen, you don't need to give progestogens. Sometimes you have a group of women who are already on systemic MHT. It means that they're on oral or transdermal MHT for the vasomotor symptom. Sometimes it's not enough to give the systemic one to treat genitourinary symptom, because this is a local problem. So on top of the systemic MHT, you would give add on low-dose vaginal estrogen for her. So what are the available hormones in Malaysia? If you have the Malaysian CPG, there are tables that I will show you later on. There's a lot to choose from. There's a lot that might be available in your center, but you might want to ask, what are the favorable ones? So favorable estrogen is the estradiol. Favorable progestogen is the micronized progesterone, for example, utrogestan, and also dydrogesterone, which usually is the duphaston. So these are the favorable group of progestogen. Favorable means it's similar to the hormone that are produced in our body, and the favorable in terms of the safety profile as well. So there are different route of administration. So actually, the favorite route is non-oral route of administration. So I will explain later on why it is favored. So whenever you can, whenever it's available, maybe you can advocate for the non-oral one. So non-oral estrogen in Malaysia comes in gel form and also spray form. And the non-oral progestogen comes as vaginal progestogen. I think many of us might be familiar with, and also the ever popular intrauterine system, the levonorgestrel intrauterine system. Okay. So again, troubleshooting. So I put up some photos. You might be familiar with how these medications look like. So again, for hysterectomized women, women with no uterus, you would give the continuous regime of the HRT. So you give a continuous estrogen only without the tablet break, and the patient would have no bleeding, obviously because she no longer has a uterus. For perimenopausal women, you give the sequential HRT. Sequential means the woman will have regular bleeding at the end of the pack. So there are two different colors here. So the first two rows are the estrogen-only tablets, and the subsequent two rows are the combined estrogen and progestogen tablet in the second half of the month. So the third regime that you need to know is a continuous regime for menopausal women with a uterus. So all the tablets look the same, and actually all the tablets are combination of estrogen and also progestogen. So again, there are many types that are available. There are many regimes. There are 3 regimes that I just explained to you. But remember that there's no one size fit all. You need to individualize the therapy, choose the right hormone, choose the right delivery method for that particular woman. And sometimes it takes trial and error as well. So again, just to recap, estrogen that are available in Malaysia can be given as pills, as gels, or as sprays, and the progestogen can be given as a tablet, either oral or vaginal tablet, and also as the intrauterine device. So the question that will come next is, how to choose the correct MHT for my patient. And I mentioned just now transdermal, the gel and the spray. Some patients might wonder, how does that work? How can it work when she just rub it on her skin? All right. So this is how transdermal medication actually works. There is a difference between topical and also transdermal. Topical just go to the epidermis layer, but transdermal goes even deeper and directly to the blood circulation. And what's good about transdermal estrogen in particular is that it bypasses the liver. So it bypasses the first pass metabolism, which makes the circulating level more stable. It does not depend on how your liver is metabolizing it. So in effect, you actually need lower administrated doses, and there's less variability from one patient to another, because it goes directly to the bloodstream, to the target tissue. So the oral route actually produces a high level of estrogen, the E1, and actually E1 is the culprit that increases the risk of VTE, stroke, and also coronary heart disease. But if you use the transdermal route, actually the skin only metabolizes the E2 to E1 to a small extent. So in effect, I mentioned just now that actually the transdermal administration, you only need a lower dose to get enough circulating E2, and you only have to a small certain extent the E1, which is the cause of the VTE and also stroke. I just would like to share with you this RCT. Tang et al. Actually tried to investigate between the efficacy of oral versus transdermal estrogen, and they found that both and the outcome that they wanted to investigate was the menopause-specific quality of life. And they found that actually, regardless whether you give oral or transdermal, there are significant improvement in quality of life, and there are no differences in the two groups. There's no difference in efficacy when you compare between transdermal and oral. So to cut short, that oral and transdermal are as efficacious, all right? So what about the safety? What about the VTE risk? So this is an ESTER study. They wanted to investigate the VTE risk of oral versus transdermal. And as you can see in this graph, the risk of VTE with transdermal estrogen use actually is comparable, or in fact slightly lower than non-use of hormone at all, whereby the oral estrogen actually is 4 times higher. And if you look at different risk profile of women with regards to BMI, you would find that even in women who has BMI more than 30, if you give transdermal estrogen, actually it is only slightly higher, or actually comparable to non-use of hormones. So what this study would like to reiterate is that for women who are at higher risk of VTE, in this case, women with a high BMI, when she needs hormone therapy, menopausal hormone therapy, then for this group of women, the transdermal would be a safe choice. So with another study trying to investigate the risk of VTE, they found that there is increased risk of VTE with the use of conjugated estrogen and estradiol, but the risk is higher in conjugated estradiol, and actually the risk increases depending on the type of progestogen that you use, the MPA, norgestrel, and the NET. Just now I've talked about the favorable progestogen. So these are favorable because it does not increase the risk of VTE. It is a dydrogesterone, transdermal estradiol, transdermal combined MHT, but transdermal combined MHT is not available in Malaysia, and also Tibolone. So you can refer to this in our CPG, Menopause CTG. This is as of 2022. These are all that are available in Malaysia in the market. All right. Next W is when to start. So this is very important. It's one of the golden rule as well. So in the absence of contraindication, MHT is an effective treatment when initiated within 10 years of the last menstrual period, or in women less than 60 years. So the key word here is initiated. So it matters when you start the medication. You must, in the absence of contraindication, you should start the MHT within 10 years of the last menstrual period, and the woman must be less than 60 years of age. But I've talked about when to start, when to stop. When to stop is actually easier than when to start. There's no set timeline. If you initiate it at the right time, the woman can continue to use MHT as long as she needs it, provided that you do a regular or an annual review of benefit and risk. As long as it is safe for her, as long as it is beneficial for her, you can continue to prescribe MHT well into her 60s or 70s or beyond. Next, why MHT? Why should we prescribe MHT? So these are the benefits of MHT on vasomotor symptoms. There are a lot of, herbal remedies, phytoestrogens, botanicals, and whatnot in the market at the moment. Of course, the woman has her prerogative. She should be empowered to make her own choice, but it is our duty as doctors to tell her that the most effective treatment to manage her vasomotor symptoms is still the menopausal hormone therapy. So you can see the stark difference in terms of the benefit on vasomotor symptoms. What about cardiovascular risk parameters? So there are many cardiovascular risk parameters here, and we've found that MHT actually reduces many of the cardiovascular risk parameters with the exception of triglycerides. So if you take a look at triglyceride, oral MHT actually increases triglyceride to a certain extent, but not the transdermal. Again, this is why transdermal is actually better than the oral. This is again the timing hypothesis on why you should initiate MHT within 10 years post-menopause or in women less than 60 years, because this is the group of women who would benefit from the treatment when coronary heart disease or cardiovascular disease is concerned. And if you start in older women, actually, there's not much benefit, and to a certain extent, there are risks as well. What about bone health? So studies have found that MHT prevents bone loss and reduces the risk of osteoporotic fracture, regardless the site of the fracture. The last MHT is where to get MHT. Hopefully after this webinar, patients can get MHT from you. The last part of my talk, I would like to address the looming shadow of breast cancer, because I feel like no matter how much you want to do your best with your patient, no matter how much you want to advocate hormone therapy, or in fact contraceptive pills or any hormonal contraception to the patient, when the patient throws the question at you, what about breast cancer, doctor? Then most of us will be stuck. We don't know how to answer, and the woman will just leave your clinic without taking the prescription. So how to tackle this question? This is a beautiful infographic published by the British Menopause Society. So if you take 1,000 women aged between 50 to 59, regardless of whatever the woman do or whatever the risk factor the woman has, out of 1,000, 23 cases will be diagnosed with breast cancer. This is the background risk or the risk in the general population. What if this 1,000 women takes combined hormone replacement therapy? Only additional 4 will get breast cancer. This is the same risk as women who takes combined hormonal contraceptive pills. But if this 1,000 women had a hysterectomy for one reason or another, and they go on to take estrogen only hormone therapy, actually there will be 4 fewer cases of breast cancer. Compare that to women who are overweight or obese. If you take 1,000 women who are overweight or obese, there would be additional 24 cases of breast cancer just because of overweight or obesity alone. And you contrast that to women who are active, who live in active lifestyle, actually there will be 7 fewer cases of breast cancer. So this is from British Menopause Society. It is readily available online. I think you can use this to help your patient navigate the question and the fear of breast cancer. So this is again the same data, only worded and put up in a slightly different way. So again, if you take 1,000 women who takes combined menopausal hormone therapy, an extra 4 out of every 1,000 women will get breast cancer. And this means actually that there's 973 out of 1,000 women who take MHD that won't get breast cancer. So it matters how you word it and how you present that information to women. And one thing to note is that if the woman uses menopausal hormone therapy for premature menopause or for premature ovarian insufficiency, the risk of breast cancer is not higher until after the age of 50. So you can safely prescribe, where breast cancer is concerned, you can safely prescribe to younger women until the average age of menopause, which is 50 years old, and it will not increase her risk of breast cancer. So what's actually killing women? Actually, it's not breast cancer, it's cardiovascular disease. And cardiovascular diseases kill more women than breast cancer and greater than all cancers combined. But women, and to a certain extent, doctors alike, are more likely to identify, less likely to identify heart disease as the leading cause of death. So we need to educate patients and we need to educate ourselves and change the narrative, I believe. What about women who cannot take hormones, or because of contraindication, or women who by principle or by choice do not want to take hormones? Of course, this deserves a lecture of its own, but let's look at what the evidence say. Actually, don't discount cognitive behavioral therapy and clinical hypnosis. Actually, there's level 1 evidence to support, especially for VMS and also for insomnia due to menopause. SNRI also has level 1 evidence. This is a new kid on the block, neurokinin B antagonist called fezolinetant. Is not yet available in Malaysia. I think it's just been FDA approved, and I think it's going to be in Malaysia next year. It's the non-hormone treatment that is targeted specifically to treat vasomotor symptoms. Okay. What about weight loss? To a certain extent, yes, weight loss helps with vasomotor symptoms, because we know that women who are overweight and obese have a higher tendency to have more severe and more frequent vasomotor symptoms. But herbal remedies, complementary alternative treatments are similar to placebo in terms of efficacy. These are special group of women. I believe they also deserve a webinar of their own, if you may. Women with primary or premature ovarian insufficiency. One thing I would like to highlight is that for this group of women, they may be asymptomatic, and the only symptom could just be the scanty period, the oligo or amenorrhea. They might not have vasomotor symptoms. But for this group of women, even though they are asymptomatic, they need to be on hormone replacement therapy for the sake of their bone health, for the sake of prevention of osteoporosis, and also for the sake of their lowering their risk of cardiovascular disease. This is similar to women in the early menopause group, because I mentioned that some guidelines actually recommend you see women with early menopause in the same light as premature ovarian insufficiency. The third special group is surgical menopause. So sometimes you remove both ovaries in a younger age group of women For surgical menopause, actually, the symptom onset would be immediately after the surgery, and the symptoms are often more severe. And these are the younger group of women who would struggle more. So, I would say think twice before you take out ovaries. Think whether you really need to remove both her ovaries, and if you do, then talk to her about hormone therapy. Other tips and tricks, again, for POI and also perimenopause, remember the versatility of oral contraceptives. Remember that if she does not desire pregnancy, then probably oral contraceptives would be a better choice for her. But with the caveat that for younger group of women, we don't really know the evidence in terms of bone health with the use of oral contraceptive. But symptom-wise, and contraceptive benefit, of course, you can advocate oral contraceptive for this group of women. And remember the versatility of the levonorgestrel IUD. So sometimes you would put in the levonorgestrel IUD because of abnormal uterine bleeding. And later on, this woman would experience menopausal symptoms, for example, vasomotor symptom. You can add on either oral estrogen only, because you already have the endometrial protection there, or you can give the transdermal estrogen only. So I've given a lot of information. Actually, all of the information that I've given are readily available online. But what I hope I had done is put things into perspective, so that the next time you look up the information, you know what to look for, and sort of streamline the information for your better understanding. So my take-home messages, number one, the most important is validate the symptoms and put the patient at the center of your treatment. Don't ignore hot flushes, because now we all know that the more intense, the more frequent hot flushes, the higher the risk of cardiovascular disease and the higher the risk of osteoporosis. Think long term. When you want to advocate for treatment, think long term, especially among early menopause and POI. But one thing I would like to say, MHT, yes, it is for osteoporosis prevention, but you cannot start just solely for the sake of reducing the risk of CVD. Okay, it is not part of the recommendation. Number 4, remember the golden rule, the timing hypothesis. In the absence of contraindication, MHT is an effective treatment when initiated within 10 years of the last menstrual period in women less than 60 years of age. And the keyword here is initiated. Initiate during the right time. You can continue for as long as it is beneficial and safe for the woman, regardless how old she might be. These are my resources, and if you would like to look online, these are the places that I suggest you start. And yeah, there's a lot of information. British Menopause Society actually has a toolkit for practitioner that you can look at. The IMS actually has a lot of resources, recorded webinars and whatnot on their YouTube channel as well. With that, I thank you. I end my sharing. I prepared a QR code that you can scan. There are many ways that you can connect with me if you have questions outside the webinar, or if you want to collaborate and whatnot. I'm always open to new things. Thank you.
Thank you so much, Dr. Hanan. In true Malaysian fashion, you have done it the cepat dan tepat way. You have wrapped it all up in under 50 minutes. So thank you for that. And also, you reminded me that I have to thank MMA Kelantan for collaborating with us, in particular, Dr. Tuan Zamani Amir, who is the chairman of MMA Kelantan, and also Dr. Wan Nur Aina, who is the vice chair. So thank you for putting all that very nicely together, and Mr. Law, who is our IT behind the scenes man, for facilitating all this. Now, on to some questions. And just so you know, Dr. Hanan, our regular participants in the women's health webinars, they always show their appreciation with those emojis. It's really sad that when we look at those recording, right, we cannot, it does not pick up those all those hearts and emojis that go up, but that's usually what yeah, that's how they motivate us lah, by sending up all those love and emojis. So that's a plus, and that basically, yeah, you see it now, but in the recording we don't get to see all those hearts, so that's sad. Coming to the question, I have a 50-year-old female patient. Her periods are now irregular, LMP 4 months ago. She complains of vasomotor symptoms. Which is best for her? Combined oral contraceptive or menopause hormone therapy?
Okay, okay, you start with a very tricky question. All right. So, yeah, for where vasomotor symptoms are concerned, you can give either or, the COC or MHT. Both can help in terms of periods, and both can help in terms of symptoms. What you might want to consider now is her contraceptive needs. Whether she is in need of contraception, because you don't want a 50-year-old to suddenly get pregnant, right? But where COC is concerned, you need to also look at her profile risk, whether it is safe for her. But if you feel that MHT is suit her risk profile better, then you can go with MHT, provided that you tell her to use added contraception, because MHT does not have the contraceptive benefit. Yeah.
Thank you for that. There you can see the thumbs up. So we have a very, very interactive gang of listeners here. Um, Next question. Is family history of breast cancer a contraindication to MHT?
Family history of breast cancer is not a contraindication. It is personal history of breast cancer. And nowadays, in the age of BRCA testing and whatnot, sometimes you would electively do a bilateral oophorectomy for a younger woman, which would put her on surgical menopause. So this patient would benefit from MHT until the average age of menopause.
I'm so glad that question was asked because just yesterday I attended when I gave a talk at CME at one of the clinic kesehatans, and the doctor there who's got this family history of breast cancer asked that same question because at some point her mammogram picked up, the doctor's mammogram picked up a small lesion, and then um, on ultrasound, she was referred to the surgical unit and to the breast surgeon. And on ultrasound, they could not see it. So even a healthcare provider, primary care physician, is concerned that given her family history plus that mammogram finding, whether she should, be using MHT or not. So thanks for that answer. Next question is a
Wait,
53-year-old.
since we're speaking about mammogram, sorry, I would just like to interrupt since we're talking about mammogram. I think quite a few frequently asked questions to me with regards to mammogram is that, do you need to do a mammogram when you start MHT? And it's not easy to schedule a mammogram. Sometimes patient need to wait, and in the waiting, the patient is suffering. So you don't need to wait for a mammogram to initiate the MHT. You can start unless you already have a mammogram report in your hand where you're concerned, then you might want to get a surgeon input or whatnot. Of course, if it's BIRATS 3 or 4, you might want to get the surgeon input first, but 1 or 2, I would say you can just start. You don't need to wait for mammogram to do. And where mammogram is concerned, if you are concerned about mammogram, tibolone actually is a good I say MHT because it doesn't increase the breast density. So when mammogram is concerned, you'll be able to easily pick up any lesions with the use of tibolone. Yeah.
Excellent. And another point to tell is that having these conversations sparks ideas and exchange of thoughts as well. So next question, a 53-year-old has undergone total hysterectomy 5 years ago. Is it okay for her to take estrogen and progesterone? I think you addressed this in your slide earlier, but go for it.
Okay, so I think I explained the golden rule that if a woman does not have her uterus, then she only need estrogen. If she has a uterus still, then she would, by all means, she need estrogen and progesterone. But there is an exception. I forgot to mention in my slides just now. You need to look at what's the indication of the hysterectomy. If the indication of the hysterectomy is endometriosis, then it is advisable to give combined estrogen and progestogen, because you don't want you for the benefit of the endometriotic lesion, the residual lesions. Yeah.
Okay. Next question is, I have a menopausal patient who is on oral HRT, MHT. However, she still complains of frequent urination and urge incontinence. Will vaginal estrogen help in this case?
Okay, thank you for this question. Definitely, vaginal estrogen will help in this case. So, if the patient is already on oral HRT, it is systemic HRT, but sometimes the benefit does not go to the vagina. So, you can add on the vaginal estrogen on top of the oral. You don't need to off the oral. The oral is for the vasomotor symptoms or whatnot that you started in the first place, but you can add on the vaginal estrogen.
Okay. How come is it contraindicated to use MHT in women with cardiovascular risk, but MHT is used to prevent cardiovascular disease?
Okay, this is quite tricky. Okay, you need to see when you want to start the MHT, you need to see the patient's risk profile. So, for example, the woman already had a history of CVA, or woman already had a history of coronary heart disease, history of MI or whatnot. So, for this woman, of course, you cannot start already. But that's why we talked about the timing hypothesis just now, the timing of initiation in the younger age group within the 10 years of menopause, and less than 60 years for this group. If she has not had cardiovascular disease yet, then it will be good to start to prevent it from occurring later on. Yeah.
Brilliant. Next question. How long does it take for, how long does the hot flashes last? Can it go on till 67 years of age?
Unfortunately, for some women, it does. I think they call it, I don't know, they call it the super flasher or something like that. There's a term for it. So I think about there is one group of women, I think about 25%, I might not quote it correctly, that continue to have vasomotor symptoms for many, many, many years. And these are the women who struggle. And that's why I said, if you initiate it in the correct window, as long as the woman needs it, you can continue, regardless of how old the woman is.
Excellent. And I'm sure the next line is echoed by many of our listeners. The Dr. Sureka says, "Thank you, Dr. Hanan, for the wonderful talk. What tests or investigations would you do before starting MHT?"
Okay, so I would first of all, you don't need to do tests to diagnose menopause, but you can take this opportunity for this health conscious woman, I would say, because these are the health conscious women who come to you to seek treatment for this. So you can take this opportunity to do a health screening for her. Because you might want to look at cardiovascular risk as well. So you can do your usual lipid testing, your diabetes testing. One thing that you might want to check, where hormone is concerned, you might want to do a thyroid function test, because some of thyroid symptoms can mimic menopause symptoms. And take the opportunity to do a holistic approach with regards to women's health. Yeah.
So, expanding that question just now, where the Dr. Sureka asked whether we should be doing any blood tests prior to starting MHT. So now we have started MHT, maybe 3 to 6 months later. Should we be looking at any particular blood test results to look whether the hormone MHT is having an impact on the woman's health status, or would that not be necessary?
I would say your compass would be the symptoms, whether it helps with the symptom or not. You treat the woman is at the center. Treat the symptom, help her with the symptoms, and the rest as a added benefit. But the things that you might want to assess during your follow-up would be the bleeding pattern. Some of them will have some irregular bleeding. Some might have breakthrough bleeding. So in the first 3 months, I would say the keyword would be perseverance until it stabilizes. But beyond that, if the bleeding is problematic, you might want to investigate why she has this problematic bleeding. Yeah.
Okay. Next scenario is a 55-year-old naturally menopause for the last 4 years and was on Fimaston 110, the dosage, for 5 years because of body aches and insomnia. She developed intermittent PV bleed for the past 1 year. And what would you recommend? Should she change to Fimaston Conti? What would the recommendation be?
Okay, so this is a good question. Sometimes certain school of thought say that after 6 months or after 1 year of 110, the bleeding regime, you might want to transition the woman to the continuous or the non-bleeding regime. Again, this is a trial and error. You can try to transition. It may help with the bleeding pattern. But for some women, they might need to go back to sequential. Again, it's a journey that you need to take with the patient. It's about patient expectation. You need to say that, this is a transition. It might work. So yes, after some time, on 110, you need to transition to Conti. Yeah.
And what about a patient with migraine with aura? Is that a contraindication to MHT?
Okay, so for COC, it is a contraindication. But for migraine per se, if you look at the guidelines, it does not say that it is a contraindication. But for safety purposes, this might be a group of women that you want to put on a transdermal.
Excellent. And what options for women with a history of stroke and having perimenopausal symptoms?
Okay, so this one, history of stroke, sadly, I think it might not be a good choice for her. You might want to explore non-hormonal. And as the same as women with breast cancer, it is contraindicated for them. You might need to do a multidisciplinary approach for these women and weigh the risk versus benefit for this particular woman.
Thank you. And slightly off topic here, but one of our participants has asked, what is your opinion or comment with regard to female androgen deficiency or insufficiency syndrome, FAIS, and estrogen implant preparations? I think that would.
Okay, I would say this is outside of my knowledge, and I don't know whether estrogen implant is available in Malaysia, but this would be something that I would read up on. Thank you for asking.
Like you stated yourself earlier, you're quite the competitive soul, but we'll save that question for the next webinar session. If a patient, coming back to the next question, if a patient with a known case of endometriosis and having menopausal symptoms, does MHT cause activation of endometriosis? And if so, how do we manage it?
Okay, so again, endometriosis. For endometriosis, I'm assuming this patient is not has not been operated on. She still has a uterus. So again, the principle is you need to give combine. Whether it causes the activation or not, I think I don't have the evidence for this. But going back to the principle, if she still has a uterus, then you need to give a combine. And I guess for me, if I have such patient, I would start weigh the benefit versus risk. What's the patient's priority and what troubles her more, and reassess from that point onwards. and reassess the patient's need. Yeah, I would say.
As you said, keeping the patient or the woman at the center of treatment.
Yeah.
Yep. Apologies, Dr. Sunita. Could you retype because I've lost that train of thought with, there's
I think it was the one just now. She asked whether the question of woman post hysterectomy, does she require progestogen or not? And rightly so, this patient has endometriotic cyst, and yes, for this particular woman, she need combined because it was endometriosis or endometriotic cyst. Yeah.
excellent. Thank you. Can the efficacy of transdermal MHT reduce in patient with obesity?
No, the efficacy I don't have the slide in terms of efficacy, but actually with transdermal, the level of the circulating estradiol is more reliable compared to oral. And where obesity is concerned, it is actually safer. And if you look at studies comparing the doses, actually transdermal estrogen requires a lower doses because it doesn't go through the first pass metabolism and it goes straight to the target organs. Yeah.
Thank you. And if a patient has osteopenia, dyslipidemia, and obesity, is transdermal MHT a better option than oral? I think you've answered that. What is the type and dose of transdermal MHT that you usually start patients on?
Okay, so transdermal, there are three that are usually available: the spray, gel. There are two types. So the principle is still the same. I find gel is better than spray because user reliability, how you spray and whatnot. Gel is more reliable in terms of user experience, but I don't know, some people might disagree. Again, the principle is you start at the lowest dose possible and look at the patient's needs and increase as needed. Yeah.
Thank you. And the next
Usually
one is
the gel, there are two types. One comes in a like a tube and one comes in a sachet. So usually is a the dose is pre-prepared. So you give the lower dose and you increase as needed. Yeah.
right. Thank you. And then the next one is a perimenopausal woman on combined oral contraceptive for vasomotor symptoms. When to switch to MHT?
Okay, again, this one depends on the woman's contraceptive needs and also whether the woman is already menopausal or not. If she's already menopausal, then obviously she doesn't need the COC anymore. If she's still menopausal, then you might want to discuss with her with regards to her contraceptive needs.
Is there a need to reduce dose of MHT, example, Fimaston Conti 110 to 1.5 after few months if a menopausal woman with obesity, dyslipidemia is on it and her vasomotor symptoms improve with it?
Okay, so one thing you need to understand is that 110 and 1.5, when you change from Famoston 1.5 to 110 to 1.5, you're not actually reducing the dose. The dose of the estradiol is the same. The 1 is the estradiol. The 5 and 10 is the progestogen. So the reason why it is 110, because you're only giving it for half of the month. That's why it's 110. If you change to Conti, it's 1.5 because you're giving 5 milligram throughout the month, every day, because Conti is combined. All the pills are estrogen plus progestogen. Yeah, so actually you're not reducing the dose. There's another version of Famoston which is 210. That means you're increasing the dose of the estrogen from 1 milligram to 2 milligrams. Yeah.
Excellent. And final question here. Before that, thank you so much, Dr. Hanan, for answering all the questions that has been coming your way. Final question for a woman um, who is 40 years and diagnosed with POI, but asymptomatic of all menopause symptoms. However, diagnosed with Raynaud's, is it a must to start MHT?
Okay, so young woman who has comorbidity that might make you feel wary whether is it safe for her to start MHT. So obviously you would want to start MHT for the sake of her long-term health. So this is the particular woman that you need to take other doctors on board and look at her risk versus benefit profile. Which one would she uh, crudely say which one would she die of, and which one is the main need for that woman. So for example, sometimes you have a breast cancer woman who is very young, and you know that is absolutely contraindicated, but she's so young, maybe she's still 30 years old, has breast cancer, and she's going to live. And you know, with our medical technology nowadays, a lot of cancer survivors are living a very long life. So you might want to involve other expertise such as her oncologist, such as her breast cancer surgeon, and look at her risk profile and which are the risks that the woman is willing to take and which route should you go on to. Yes.
Just as I said, that was the last question. Somebody snuck in the final question. Okay, so guys, stop typing
Final,
question.
final dot,
Yeah,
final
yeah,
dot.
final, final already.
Dot.
So stop typing, and we'll end it with this question. Do you recommend any particular vitamins or minerals in perimenopausal women, and your view on remifemin?
Okay, so um, vitamins and minerals, this one is quite a frequently asked question. So if you want to recommend supplement or vitamin, there's a lot. But I would say based on experience, what I would advocate nowadays is vitamin D, because now we know that many Malaysians are vitamin D deficient. You might want to start there. And there's a new vitamin called new kid on the block called K2. So this is for the metabolism of your calcium. It takes away the calcium from your blood vessels and channels the calcium to your bones. So you might want to read up on that and find out more on that. Other than that, you need to tailor to the woman's specific needs. Yeah. And remifemin, I would say, yes, a woman need to have her own prerogative, but it needs to be an informed choice. We still need to tell women that for her symptom, the most effective is still menopausal hormone therapy. But if she choose otherwise, then we just need to be supportive of her journey. Yeah.
As I said at the beginning of this talk, a very empathetic doctor in the house. So, supportive of her journey. Thank you for that. Thank you for taking all the questions. And I think Dr. Sunita sums it up very nicely. She has put in the Q&A box. Thank you, Dr. Hanan, for the wonderful talk and for answering all the questions. We cannot thank you enough for the sharing session. And I also would like to give a shout out to all our participants. You can see the emojis going there past 9:18. It's 9:18 p.m. and we have more than 200 people sitting there in the house. Thank you for the love, affection, and the attention. MMA's, yeah, perfect. MMA's Women's Health Committee hopes to see you next month with another one of our informative talks. As we say, raising awareness through education, RETE, raising awareness through education. With that, I thank you and have a wonderful evening ahead. Thank you. Thank you, Dr. Hanan.
Thank you, Dr. Siva. Thank you, MMA. Thank you, everyone.